Hey, welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, December 23rd, 2024. Today and next week, I'm joined by Dr. Aria Grillo. Aria is a clinical psychologist and also a patient of ours at MFM Associates in New York City. Aria and I sat down last month for close to 2 hours to talk about her pregnancies, psychology, medicine, and life. She has such a great perspective on the entire process, both generally as well as specifically through the lens of clinical psychology. I think we probably could have spoken all day if we had the time. I'm sure you're going to enjoy these podcasts. Think of them as a nice holiday treat. Wishing all of you a wonderful Christmas, Hanukkah, Kwanzaa, and anything else you may be celebrating this week. Also, big shout out to my parents, Barbara and Jack Fox, who are celebrating their 60th, 6-0, wedding anniversary this week. All right, thanks for listening. See y'all next week. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. Aria, welcome to the podcast.
Thank you. I'm so happy to be here.
Formal name, Dr. Aria B. Grillo. And yes. I was asking you, what does the B stand for? Does it mean be cool?
Yes, it does. It means that my mom actually has 5 sisters, and many of them had daughters. And so one of the things they did was have Bergantini as the legal middle name to carry on the last name of my grandfather, since he was thrilled to have 6 daughters.
Right.
But it was a way to carry on.
So the Bergantinis live on through your middle names.
It's true. Yes, it does.
That's right. So listen, I'm so excited to have you here on the podcast in person.
You.
This is a long time coming.
I know.
We've been speaking of this since
the birth of my son.
Before the birth of your son.
Yeah, that's true.
I mean, we were talking about this during the pregnancy, that you're going to come on. Say, after you give birth, you're going to come back and come on. So, and we are now recording, it's November, and your daughter was born in August.
Yes, she just turned 3 months.
And your son just turned 3 years. So we've been talking about this for 3 to 4 years now.
Exactly.
Unbelievable. Here we are. You look terrific.
Thank you.
How are you doing with a newborn? 2 kids at home, one of them being newborn. How are you rolling with that? You sleeping at all?
In theory. I like to say to people, it feels like 2 very different television shows are on at the same time. Like there's this one loud, like Minions are blasting. And then there's also this like classical music playing at the same time. And so it's about how do you navigate the 2 intensities of 2 completely different television shows, which are on at the same time in your house.
Yeah, so my first 2 kids were also a boy and a girl. They were twins, right? And so people would ask all the time, what's it like having twins? Like, is it harder? And I said, well, I don't really know the alternative, right? I never really had that. But I said, I would imagine, and I believe this to be true, that having twins is not twice as hard as having a newborn. And it's probably not as hard as having a 3-year-old and a newborn. Right. Because that is, one of them is running out the door and one of them is like, needs to be fed.
Right.
And whereas if they're twins, I'd say twins is like 1.6 times as hard as having one, I would say. Because, you feed one, you feed 2.
Right.
You bathe one, you bathe 2. You put one in the stroller, you put both in the stroller. They both go to the doctor at the same time. Like there's some...
They can't escape.
Yeah. There's some economy of scale, as we say with these things. So that's good. All right. So excellent. So I'm so happy you're here. And then professionally, tell us what you do professionally.
So I'm a licensed clinical psychologist and I work in private practice and I also work in the hospital setting as well. So child, adolescent, across the lifespan, feelings doctor.
And you're a graduate of the Great PsyD program at Furkoff.
Yes, I am.
Which is also the institution that graduated my wife from the same program, literally the same program. And my daughter Kira is now a first-year student in the same program.
It's a fabulous program. So, I can't say enough wonderful things about that program. And I'm so glad she's there.
Yeah, no, we are too. She's
strong alumni.
Yeah, for the record, she's enjoying it very much. She's really happy. And so, when we were talking about this day, about us podcasting together, there's a lot of things that sort of came to mind of what would be cool for us to talk about. And we're going to get to all of them. But I guess let's start with you. So just for our listeners, introduce yourself. This is an open-ended question, sort of where you're from, where you grew up, where you went to school, how you got into psychology, like all this, just so we get a flavor of the beauty of your soul, where it comes from.
Well, I think that's such a wonderful way to explain it. I think when I think about who I am and who I have become, there's so many versions of who I am. I'm a native New Yorker, born and raised in the city. And I think that is a flavor of who I am and what it means to grow up in a place like this. And then went to college in Massachusetts and knew right away that I loved psychology. I always wanted to be in very specific pediatric psychology.
How did you know that?
I think my mother's a journalist, and I think she's a journalist, playwright, and there's that knack of asking the right questions and storytelling. And I think that I was always very in tune to what is somebody else's story. I want to know your story. I also, at a very young age, knew that I really wanted to be in a hospital setting, which was actually rooted in a traumatic experience. I had a traumatic brain injury when I was 15, walking down the street in Union Square, and a giant door fell off a truck, hit me in the head, could have killed me. I ended up at St. Vincent's, which is no longer there, but a wonderful PICU. And I was 15. And so that's a real turning point age where you're starting to see that you have some autonomy. You have a voice. You're not a little kid anymore.
Right.
And yet you still need mom and dad to sign things for you. And yet people were asking me, like, how are you doing? How are you feeling? And I was realizing, hey, wait a minute, my voice actually matters here. It was also the first time I really noticed the difference between providers who didn't talk to me, talked right to my parents, and the providers that looked right at me and said, hey, you're on this team.
Right.
How are you feeling?
Yeah.
And that resonated with me, that I thought, wow, what a shift.
Right.
This experience could have been really awful if I hadn't had some providers that really said, hey. And I think that just stuck with me, that kids have a valid voice, teenagers, valid voice. We all have a valid voice. You just need to make sure you're with the right person, asking the right questions. So that sort of took me on my journey, my long, winding journey to actually be that provider.
And that journey definitely went in different directions.
Yes. I worked in fashion for a while. I worked in marketing. I worked for nonprofits, really trying to find my footing, figure out what I wanted to really do, always knowing in the back of my mind that, working with people, taking care of people was something that I wanted to do. I wasn't ready to commit to what ended up being about 10 years combined of the doctorate program until I was absolutely ready. And I'll tell you this quick story. We were actually on our honeymoon and we were in Greece, and there's some lookout point where you're supposed to go and stand and like take in the wonders of the world. And it's so perilous that you can't have your phone out. You really have to experience this moment. And everyone single file went to this lookout point and experienced the world. And people are coming back saying, oh, wow, I feel so small in this giant world. And the earth is so beautiful and blah, blah, blah. And I go out and I come back, tears coming down my face. And everyone said, what did you see? And I said, if I don't go back to graduate school and get my doctorate, I'm never going to go. And they're like, that's what you saw? And so I literally flew home and reached out to the director at Furkoff and said, I need to apply. What do I do? So
wow,
there you go.
Wow. Did you have to do any post or whatever they call it? Did you have to take any courses before applying, or you were able to apply? Because for medical school, you have to do that. I don't know what it's like for psychology
I had a lot of relevant experience and it wasn't very recent. And so I needed to really zhuzh up the CV. So what I did was I did my...
right, I'm holding your CV. It's big and thick. So you've done good work.
Yes, thank you. I got my master's in mental health counseling, and that really was a perfect way to sort of set the groundwork, get some real experience to see which doctorate program I really wanted to go to. And that's how I got to Furkoff.
And you chose the school child clinical because you knew you wanted to work with that age group.
Yes.
Those you said who have a valid voice. I would say the teenagers have a voice.
Yes.
Whether it's valid or not, that remains to be seen based on the teenager.
It's very valid, depending on the topic. Yeah, but it's the same. I think that it's still such a perilous time where, you're relying so much on your parents to make decisions that you forget that, and especially that 18, 19, 20 is, you don't see your pediatrician anymore that you've seen your whole life. And now you have to see this other person.
Right.
And now you're an adult. Who said that? Like,
what? You're voting.
You wake up and you're an adult.
Yeah. You could do anything at 18.
Right.
And you're not quite fully developed yet from a brain perspective.
No,
it's an interesting time.
Solidly until 25 where that frontal lobe is making sound decisions. So there's so much anxiety. So yes, I try to be, as best I can, a real conduit to having that, helping to navigate the frenetic world.
Right. So who do you see in your, so you finished your training and then you've been in a lot of different sort of clinical positions. Yeah. But right now, like, who do you see in your private practice?
So I see across the lifespan. I see teenagers, I see adults. Yeah. So teens through adulthood.
And what would you say your, like, what's bread and butter? Like, what are you mostly seeing people for? Is it anxiety? Is it depression? Is it sort of life skills, organizational? So like, what are you doing typically?
I think it's like one sort of begets the other in terms of like some people have a lot of anxiety and they are very overwhelmed and they need those executive functioning skills. They need the organization skills. Others, I think it's really interesting, and we've talked about this a lot, especially when we talk about pregnancy. People measure like, well, I'm depressed, but I'm not very depressed. So maybe I don't need the level of help that someone who's very depressed might need. And so really trying to tell anybody, if you think you're depressed, let's work on that. You're depressed. You don't need to be measuring what's the clinical level. We will do that. And use that to sort of decide, are you able to get out of bed in the morning and go to work? Or does that feel too overwhelming to you? Okay, that's a level. And yet, if you are stressed about your life, your job, if you're wondering if you need to make a career change, the state of the world is bearing down on you, that's all valid. There's no like Likert scale of, how you are feeling. So, and the same thing with anxiety. Anxiety, I think I tell especially my kid patients all the time, we should all have anxiety. Some level.
It keeps us from getting hit by buses.
Exactly. That's the literal example I use. Why, when you have the walk sign, do you still look both ways? Because there's a chance. Now, if you're looking both ways and you're in an aisle of a supermarket, that might be something we need to talk about. But it's more...
Well, you get hit by a cart, I assume,
And or those creepy robots that follow you around now. Have you seen those?
Oh God, no.
Yes, they have.
I don't spend too much time in supermarkets, thank God. So, but there are robots that follow you?
There are, in some supermarkets, they have these robots that sort of follow you from an awkward distance and you make eye contact. It's like an optical eye. I've never engaged with it.
Are they there to help you shop or to keep you from stealing? Like
it could be both. I don't know. It looks like maybe it's a RoboCop and it immediately turns into a bad cop. I don't know. I think it's supposed to help you find what you need. You have to look them up. It reminds me of WALL-E, and I feel like we're all supposed to be like in line and following the orders.
Okay. All right. So we were talking about anxiety. Yes. We digress.
But so I think in terms of the bread and butter in that realm, it's definitely a lot of anxiety and depression and validating those thoughts and feelings and how do we use skills and strategies we might already have at an amplified level to sort of work through it, reduce it as best we can. Is medication required? Working with a psychiatrist. So I usually work in tandem with a team to make sure, it's also okay. Just like if you have a headache, just like if you have the flu, there are times when medication is important and needed to help you feel your best self and really helping people navigate that process too.
Yeah. It's interesting. Only, I have some insight into the world of psychology only because I'm married to a psychologist and, again, my daughter's going to this. So that's my sort of like clinical sort of insight into it. And what I found that's interesting, I think a lot of people believe that if you're going to see a psychologist, they think of like Freud. You're going to be like lying on a couch and looking at the ceiling and talking about your mother. And they're going to be like taking a watch and dangling and hypnotizing you. And it's like I think it's a little like spooky. But And there probably are people who do that in psychotherapy and this, that, but I found that the majority of psychologists I run into in their practice, they're problem solvers.
Right.
It's like, what's your problem? How do we address your problem?
Right.
It's meant to be more practical
Right.
and not psychodynamic in the sense like, let's get to the root of why. Like maybe there's some of that,
Right.
but it's much more like, all right, like how do you get the hell out of bed and go to work
Right.
with all this? Like, what are we going to do?
Right.
And I think that people don't realize that it's much more of, there's so much of like a coaching element that comes with being a psychologist, like, and it's going to be different for every person. What is the strategy and that person's going to need that might not be related to the psychodynamics of it? It's just like, this is what's going to work for you.
Yes. No, I think there's many a New Yorker cartoon or like a Woody Allen movie that just makes you think that you should just be like on the couch facing the wall. That is very much not the case across the board. I do see it's almost like, almost working with like a gardener in the sense of like, how fertile is your soil? Like, what's going on? Are your roots knotted up on something and that's sort of hindering growth? Like, are you in the right amount of sunlight? Like, what's going on physically, internally, externally to help your garden literally grow?
What a metaphor. And you're wearing a green sweater, so that works out nicely.
And I have like an aloe I can't die. I can't kill. So I wouldn't say that I am any way of a literal gardener. But it's all about nurturing, and it's all about sort of using what you have to help strengthen yourself. I think, as you said about problem solving, I think it's really important to think about if you're looking at things from a cognitive behavioral therapy perspective, CBT, that can be very problem solving.
Right.
Like,
CBT, not CBD.
Yes.
Right.
Which other gardeners, different type of gardening.
Yeah. Okay.
So yes, CBT, problem solving. Let's make a hierarchy of where are your fears and what's on a scale of 1 to 10, where are we at? How do we reduce that? And then you look at DBT, the dialectical behavioral therapy, that I think also looks at problem solving, but more on the sense of, the intensity of an emotion. How do we turn the dial up or dial down? Let's not delete the emotion. Emotions are so important. We're not saying the problem solved is get rid of the emotion, but it's, what do we need to do with the emotion? Is it something that we need to nurture and figure out how best to navigate the problem? Or is it something that you might be feeling something too intensely, and let's just sort of turn the volume down on that? So that's how, so I would say in the psych world, I would say I'm an integrated psychologist. I pull from the psychodynamic. I pull from CBT, DBT, because every single person, and I think this is why you and I became buddies, is because every single person who walks into your office who is pregnant is not like the person that just walked out. And I feel that way about my patients. Every single person I've seen with anxiety, every single person I've seen on the spectrum, or with even extremely acute condition, someone who might be having bipolar, psychosis, or something emergent. I treat it as, I'm going to take all I know to help you, and I'm also going to look at you as who you are, not a statistic or anything. And I think that's why, despite you being outnumbered in your house by psychologists, you come from that same realm. Right. What did you call it?
Gynecology?
Gynecology.
Yeah. No, listen, and I've been very open about this, that to my patients, to my family, on the podcast, that, my clinical training, in quotes, ended in 2008. And that's when I started in practice. And so everybody knows that even when you start in practice, you're always learning, right? You're never done learning because things change and there's so much to learn. You never learn everything. Fine. The thing that I have learned the most, meaning the delta between where I started, where I am now, is greatest for human psychology, because you can read in a book and you can learn about diabetes and preterm birth and stillbirth and whatever it might be, and improve on your scientific knowledge and maybe even on your how to talk to people about it type of skills. But to understand the person who experiences this and what they're going through and the emotions and the baggage and the guilt and the anxiety, like all of that,
fear,
you cannot understand until you do.
Right.
Until you talk to more and more people and listen to them and understand. And also you get older, you have more experiences in life with family and friends and what they go through and what you yourself go through. And so I am in such a different place now than I was then in terms of, and obviously there's ways to go in terms of trying to either understand or empathize, or again, based on what we're talking about with what people are going through with that experience. And that is so deep, right? I mean, it's just so much, and it's amazing. Not always good amazing, sometimes bad amazing, but it's just remarkable.
But I would wager that was who you were pre-2008 as well, in terms of, I think that's what sets you apart from other providers. And I've heard this from...
Let's do this. All right. This is I'll take it.
It's true.
Blow that smoke.
Listen. I have spoken to lots of people who have seen you. And I think there's something to be said, especially as a male. We've talked about this as well. And the difference that people have experienced with female providers in the obstetrics world. And that sort of assumption of there's no way you could possibly understand.
Right.
And again, that goes back to now, when I've had patients who are on the spectrum or have a diagnosis that I do not have a direct, I don't understand. Right. I'm just going to do the best I can to help. And so I think that is something that is a very big strength of yours.
I appreciate that. Thank you. I think that nowadays, and by nowadays, let's say the past 20 years, I think that if you look at people who go into OBGYN, it's ballpark 90% women. Now, 50 years ago, it wasn't, but just also people went into medicine. It was, right, currently, give or take, in medical schools, it's 50-50, men and women, plus minus slightly. And whereas 50 years ago, it was probably 90-10 men or whatever it was. It was obviously very lopsided. So it's even in terms of the number of medical students, but there's certain fields that for whatever reason attract one of the sexes versus the other. And OBGYN is about 90% women, 10% men. But I think that the 10% of men who choose to go into OBGYN typically are those who have always been comfortable talking to women, whether that's having friends or whatever it might be, that we have a level of comfort. Either, maybe you grew up with cousins or sisters or just the way you are, you're wired or whatever it is. But yeah, I tell people all the time, they're like, I don't know what labor's like. I don't know what an epidural's like. I don't know what having a CVS, like I've never had them, but I've done them and I've been around the block and it's no different. I don't think my oncologist has to be someone who had cancer. And I don't think that my orthopedist has to have someone had their ACL repaired. And, and if someone doesn't buy that and they want to see female providers, God bless them. I don't that's cool. Like anyone can see whoever they want. There's, whoever works for them is fine. But I don't agree with the premise that your doctor or your psychologist or your whoever has to have personal experience with that condition in order to be a good provider for you. That just doesn't make sense in any other aspect of medicine. So why would it be the case for OBGYN? Like if the person is someone who listens to you and validates your thoughts and feelings and answers your questions and is available to you and is competent and treats you kindly, who gives a crap if they've been pregnant before? I mean, listen, most of the people who go into OB when they start haven't themselves had children yet. Right? They've had periods. Okay. But does that mean that they're not good until they have a child? That makes no sense to me.
That's why I think this field that you're in, and even in my field, there's a predominant level of female clinical psychologists.
Yeah.
We had a few in our graduating cohort and few more that came up in the next. But I do think this also goes to the idea of these assumptions.
Yeah.
That if you are a female provider, then you must have better bedside manner than a male provider because because you're a woman. There's the assumption that, you clearly, if you don't have children, you must be having them, which isn't true, right? I'm sure there are many female OBGYNs who have no children and have no interest in having children. And so they're on the same playing field.
Or can't have children, have difficulty having children. Yeah.
Right. I think nowadays with the advent of so much information that's available on the interwebs, I think people are realizing that there's far more options that people have of their lives and choices that they can make or not make, and that they're seeing that it also applies to providers. I think they're not that long ago, I would probably say probably 15, 20 years ago, there felt far more of a wall between the provider and the patient in terms of many levels of care that you wouldn't engage as much as I think people are doing now on both sides, men and women, that there's more of a comfort in talking about how you're feeling, asking questions. And that also goes back to if you're a good provider, then it shouldn't even matter, if you've had any lived experience that I've had.
Yeah, fair. And so it's actually a really good segue because I wanted to talk about your own experience when you started your journey into procreation and how that, A, what it was, just because there's a story there, and B, how it impacted you, and also maybe how it flipped how you are as a provider, sort of becoming the patient, so to speak, right? So yeah, start from the beginning. Tell us your tale.
So I was born, May 3rd. No. I think that what I think is funny, and I've talked to a lot of friends about this, is one of the great lies of our time, there's many, is this idea that when you're ready to have kids, the minute you start, the minute there is no prophylactic to be seen, you will get pregnant. Just that first time.
Yeah.
You're like, I'm ready to get pregnant, I shall get pregnant.
Especially because for the preceding X amount of years, everyone's always saying, if you don't use contraception, you're going to get pregnant, my friend.
Yes. The minute, And look, there are many people who, unfortunately, that happens, right? But it is very much ingrained in you from a variety of sources, from school, from religious institutions, from your parents, from things you see online, things you've read, that, the minute you have unprotected sex, you will get pregnant. And, I think I felt pretty foolish that I sort of believed that mindset. Like, okay, I'm married and I am in a good place. This month feels like a good month to me. I would like to get pregnant now. Like almost like I'd like to go and have this transaction. Here is my ticket. It's my turn at the butcher's counter. Please give me a pregnancy. And that didn't happen. And then it kept not happening. And I really started to immediately have this reaction of, what am I doing wrong? And I really was holding both sides here, as a provider and as a person, saying, hey, wait a second, cut yourself some slack. You're not doing anything wrong. But also really listening to myself, that I was saying, it must be me. I must be doing something wrong. And really starting to read up on the fact that, hey, guess what? I think it's like 13% of people on a first try without any assistance, during a 48-hour window, on a full moon, if you stand on one leg, there's a 13% chance. And I just was so floored that I didn't realize that. And then we did get pregnant, and I thought, okay, this is great. Everything's wonderful. I'm going to forget all that just happened because now I'm on the right course. And I think I was about 3 months pregnant, about 12 weeks pregnant, when I went in for, a routine sonogram. And this was not the height of COVID, but it was COVID time. So I had to go by myself. Everyone's wearing masks. It actually was, 2020 and 2020. So, still COVID. And
it was still happening.
It was still happening in full force. And I remember, it was almost like out of a movie, that the tech was looking at the screen and looking down, looking at the screen and looking down and not looking at me. And then sort of was like, I could tell it couldn't get a heartbeat, no heartbeat, no heartbeat. And I'm looking at this screen and I can tell, and I know she can tell, but she's not saying anything. And, she said, come with me to talk to the doctor. And I was in complete shock because, again, I'd never been pregnant before. I had no idea if this is something that happened routinely, that maybe something was wrong with the machine. I think deep down I knew something, the alarms were going off, something's wrong. And I went and I waited for the doctor, and she came in And the first thing she said was, okay, this happens every day. And then proceeded to say that the pregnancy was no longer viable. And I remember thinking to myself, boy, you should have said anything else.
Bad delivery.
That was a bad delivery. And I think this is my own protective factor is I immediately put on my provider hat and sort of, had a full conversation with her about that's not how you should say things like that. I actually was in such shock about it that it was like a week or two later that I met with her on Zoom and I said, I've had some time to process this and I just wanted you to know this is how that made me feel. Mm-hmm. And it wasn't great. That was I knew exactly what you meant. Mm-hmm. And yet saying that was mm-hmm. not at all.
Did she appreciate having that conversation? Did you come off like, who the hell are you to tell me this? Because doctors, we could be a surly bunch.
Yes.
We're not always, we're not always open to constructive criticism. I mean, although we should be, we're not always,
I would say, I think I probably had some trauma cojones in that moment because thinking back, like, where did I get off, like saying to her, like, I would like you to meet with me on this Zoom so I can talk to you about.
There's nothing wrong. First of all, there's 100% nothing wrong with that. Absolutely. That's. I'm just wondering how she responded to it.
She was very receptive.
Okay.
I said,
good.
I just want you, and I said, I know that I come from a unique position, having worked in a clinical setting throughout my entire career. I knew exactly what you were trying to say, that this is not my fault.
Right.
This happens every day. And in a bizarre way, having a miscarriage is actually, correct me if I'm wrong, but a great way to show that your body is working and that you are able to get pregnant.
Right. It's the silver lining of a bad cloud that problems A, B, and C do not seem to be present, which was obviously a concern of yours because you weren't getting pregnant at first.
Right.
And problem D, the miscarriage, is almost always just luck of the draw, bad roll of the dice, nothing you can do one way or another. So, okay, it sucks that you're going through a miscarriage, but the implication for your next time around is actually positive, that it should work next time around versus your host.
And that's what I tried to say to her. I said, I knew that you were coming in with all of that information behind you. I want you to remember that, yes, this does happen every day.
But not to me.
Right. Not to me and not to the next person who comes in. If the people who were waiting in that waiting room with me saw me skip into that room and then saw me walk out. Yeah. And I can only imagine what they were thinking. And from my own experience, I would have also thought, am I next? Is something wrong? And it turns out one of my best friends and I ended up going through miscarriages at the same time, having to have D&Cs at the same time. And it made me realize, despite you feeling so alone, because it's happening to only you.
Right.
It's not happening to your partner. It's not happening to your friends. It's only happening to you, that it is so important to realize that, yes, this does happen every day. And there's a way to say it in a way that is a far more softer delivery than the way it was said to me. And I think she was receptive. And she made the time for me to have the meeting.
Yeah.
I said, I'm not going to be with the practice anymore.
This will be our last meeting.
This is going to be.
Yeah, for the record, everyone, that was not with us.
No. Actually, that's how I got to you guys.
For those of us listening who might be in clinical care, I would say the way to open that conversation is, I'm so sorry. That's usually a good way to start with bad news, because start with that, and you can come later to the this happens every day line. Throw that at the end maybe.
Well, again, I think that's something that is known to you. It's intuitive, and I do think it's important to anyone who's listening who is a provider. Say the obvious.
Right.
Say the thing that you think is already known.
Yeah.
Because even if it's already known, I'm so sorry.
Yeah.
Or this is a lot.
Yeah.
I'm going to say a lot of things. And if you have any questions, jump out and say them. If 2 hours from now you have questions, call back. Yeah. It's okay. This is a lot.
Yeah.
And even a completely perfect, wonderful pregnancy, is a lot.
Yeah.
That's what it's all about, is to be able to sort of notice that this is all a lot, even though you see it every day.
Mm-hmm.
And so that, I'm so thankful that I had friends that I was able to reach out to and say, we've had this loss but I want to get pregnant again. And I definitely had a lot of people in my family saying, oh, are you going to be okay? That sounds scary. And, that sort of advocacy that I find so important for women is, how strong are we to go through these things, have a pregnancy, have a loss, have to have surgery, and turn around and say, and I still want to do this.
Yeah.
How do I do this? And it was thankfully a friend of mine who delivered her daughter here who said, there's this wonderful practice uptown and they will treat you better. And that's how I got here. And I came in, with my armor fully on.
Yeah.
I was not taking any jokes.
You came in heavy.
And of course I met with Dr. Silverstein, who's like this wonderful, affable Mr. Jokes. And I was like, I know I'm not falling for your jokes. He was wearing a Marvin the Martian tie. And I just thought, you can't make me laugh. I am traumatized. And yet, with time, I was able to sort of protect myself, the wounded side, and sort of take a deep breath and have this wonderful team that has now seen me through 2 beautiful pregnancies.
Thank you for listening to the Healthful Woman Podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.